Hello, everyone. Thank you for joining us again here today. Thank you for your patience. I think we are ready to get started. So my name is Jenna Reynolds, and I'm with the Asthma Society of Canada. Before we begin, we'd just like to go over a few technical items. Hopefully everyone can hear me. If you are able to hear me, if you could just please type yes or I can hear you into the chat box. You will see it on the bottom left-hand side, just so we know that our mics are working. Wonderful. I am seeing some people say that they can hear me. Also, we are recording this meeting, so if you do miss anything or would like to go back and hear something again, just ask us and we'll be happy to share that with you. In terms of asking questions and having comments, we will be happy to answer any of those questions throughout the webinar, both to our individual presenters and to the Asthma Society, and we'll have time at the end as well. If you do have questions at any time, please feel free to type them into the chat box, and we will make sure to get to them at appropriate times during the breaks. We also have a few polling questions pop up throughout, so please just click on an answer and then press submit vote just to get a little more questions. Again, thank you for joining us, and now I'm going to be passing it on to our moderator, Noah Farber.
Perfect. Thanks, Jenna. So my name is Noah Farber. I'm the Executive Director of the National Asthma Patient Alliance. I am also the Director of Communications and Government Relations here at the Asthma Society. My contact info is on the screen, so please feel free to drop me a line during, probably not during, but after the webinar. Happy to answer any questions that people might have. And the other thing to mention is that this is our first webinar in our patient education series that we have started with NAPA. Our hope is that we will make this a regular occurrence throughout 2015. This is our first run at this, so any feedback that people have would be very much appreciated, but also please feel free to be in touch with us. Have suggestions for future webinar topics. We're looking to put together a series that people find interesting and relevant, and obviously your feedback is key to us doing that. I'm going to talk just a little bit about the Asthma Society of Canada and NAPA for those of you who are not familiar with us. The Asthma Society of Canada is just over 40 years old, having started in 1974. And we work to empower children and adults with asthma in Canada to live active and symptom-free lives. We provide a variety of print and digital resources to asthma patients and people with respiratory allergies, as well as asthma clinics, hospitals, doctors' offices across the country. We're also engaged in a variety of advocacy activities, which brings us into our NAPA program. So the National Asthma Patient Alliance is a little over 7 years old. It was established in 2007 in Hamilton, Ontario, and it's a grassroots membership-based organization that operates within the Asthma Society of Canada. And so NAPA works at increasing patient awareness about asthma control, provides communications and advocacy needs for people with asthma, as well as building a volunteer network of patient volunteers that operates through our NAPA Patient Executive Committee. I know we have a few of our executive members on the call today, and I appreciate them as well as you all for joining us. I'll mention now, because I think it's a good time to make this plug, that we'll soon be opening up our nominations for our 2015 NAPA Executive Committee. So if that is something that you would be interested in serving on our volunteer committee, which meets by teleconference for an hour roughly every 2 months, please send me an email, and we'll be sending out an email blast about that probably in early December. That executive committee has representation across the country with members from almost every province, and we are involved in a variety of activities. The Asthma Patient Bill of Rights was one of the original activities of the organization, but it also supports our Team Asthma program, which has runners participating in organized race events across the country. Our volunteer program, the Asthma program, which provides peer-to-peer education support in local communities across the country, as well as a variety of advocacy campaigns. Like I said, this series is just a webinar series that we are working to develop. We felt that this topic, influenza and asthma, was an ideal place for us to start, given the timing of this. And I think we'll take this opportunity, Jenna, to maybe put up our first poll question. So you should see a poll pop up onto your screen in the next minute or so. And if you could just please select an answer, and we'll leave it up there for a little bit of time so we can give everybody a chance to reply. So you'll see the question on your screen now. Have you received your flu shot this year? Yes, no, or no, but you're planning on doing so shortly. So if everyone could please answer that poll, and then we will move right into our webinar. So we see that about 50% have not received your flu shot yet. So we hope that by the end of this webinar, you will be motivated to go out and get your flu shot for yourself and for your family. We'll let this run for a couple seconds here, and then we'll move on to our first speaker. Thank you, everybody, for participating. That poll now. So we're pleased to be joined today by three distinguished speakers. Dr. Shelly McNeil is Professor of Medicine at Dalhousie University and Vice Chair of Immunization. We're also joined by Rob Van Exan, who's the Director of Immunization Policy at Sanofi Pasteur, and finally Lynn, the Medical Advisor for FluMist from AstraZeneca Canada. So we're really pleased that the three of them are able to join us, and we look forward to their presentations. Dr. Shelly McNeil is currently a professor of medicine with a cross appointment to the Department of Pediatrics. She's a clinician scientist at the Canadian Centre for Vaccinology in Halifax, where her research focuses on immunization policy and program evaluation. She's a member of the National Advisory Committee on Immunization, Nova Scotia Infectious Diseases Expert Advisory Group, and is the Vice Chair of Immunize Canada. So we're pleased to have Dr. McNeil join us, and I will pass the presentation over to her.
Thank you very much, Noah. So thanks so much for having me. It's a pleasure to get a chance to talk to this group, and it's also been very interesting for me to have the opportunity to work with you all on Immunize Canada. So I was asked to give an overview of influenza and its relationship with asthma, and a brief discussion of the available vaccines and evidence supporting their use in people with asthma. I am a researcher, so that was a disclosure slide just to let you know that I do have research grants from pretty much everyone who makes vaccines, but certainly today I'm speaking for myself and based on the recommendations made by the National Advisory Committee on Immunization around who should receive vaccines. So I just wanted to go over some common signs and symptoms of influenza, because sometimes it's difficult for people to understand the difference between influenza and other viral infections that cause the common cold and how to distinguish between the two. I'm going to talk a little bit about the specific risks that influenza poses to people with asthma from the perspective of an increased risk of complications due to influenza. Tell you about who should receive influenza vaccine, who we recommend receives the vaccine each year, and then a little bit about what the available options you have for choosing vaccination. So influenza is a respiratory virus. It's a virus that's spread by droplets, so that means that it's in secretions when people cough and sneeze, but it doesn't travel very far, so it's a fairly close contact. You have to be in fairly close contact to catch it. Generally, we say about 3 meters, within about 3 meters, and you can see from the picture that when people cough or sneeze, they are sort of spreading lots of droplets into their environment. So it's a relatively easy infection to catch person to person. It also can live on surfaces, on hard surfaces, anywhere from a couple of hours to up to 8 hours, depending. So when we talk about hand washing and trips to the mall and the like, this is one of the main reasons we see those antiseptic wipes on the handles of grocery carts and the like, and that's because influenza and other respiratory viruses in particular can live on those surfaces for quite a while. So even if you're not in direct contact with someone with influenza, you could pick it up even just out and about doing your daily activities. It is a respiratory infection, so it infects the lungs and the upper airways, the nose and the lungs. So it's not an illness associated typically with diarrhea and vomiting. So when people use the term flu, I had the flu to describe diarrhea and vomiting, they're not talking about influenza. They're talking about other types of viruses. So influenza specifically affects the respiratory tract. It's usually associated with a fairly abrupt onset of fever, shaking, chills sometimes, often with diffuse muscle aches, and many patients describe pain, sort of headache, but more specifically pain sort of behind the eyes. And it's almost always associated with cough. So the main things that distinguish influenza from other respiratory viruses that cause general colds is typically fever and cough. It's much less common to see fever, particularly in adults with viruses other than influenza, and most of those viruses are not associated with significant cough. So when we see fever and cough together, particularly, I'll talk a little bit about the season, influenza season, and the fact that it mostly happens in winter. But during the winter season, when we know influenza's around, having both a fever and a cough is pretty predictive of actually having influenza compared to other viruses. The other thing that differentiates influenza from other viruses that cause sort of upper respiratory infections or colds is that the symptoms generally last longer. Typically, the most severe symptoms last about 5 days and even up to 7 days, and the cough associated with influenza infection can last even longer than that. So that tends to be much longer than you would see with other respiratory viruses causing the common cold. In people whose immune system doesn't function normally, or in people with asthma, sometimes the symptoms can be prolonged. So asthmatics will often experience a worsening of their asthma symptoms with influenza infection, as well as with other respiratory viruses. And compared to other people without asthma, their symptoms tend to last longer. Importantly, cough tends to last quite a bit longer in people whose immune system isn't functioning normally or people who have asthma. Long-term oral steroids, which are sometimes used for the management of asthma, can make the symptoms of influenza even more severe and last even longer. I mentioned that fever is a common manifestation of influenza. It is common in both children and adults, but it tends to be higher grade fever in children. And sometimes in young children, fever associated with influenza can be associated with what's called febrile seizures, so convulsions related to the high fever. So that's the typical course of illness, sort of 5 to 7 days of high fever and cough and the like. But there are some patients that are people that are much more at risk for complications of influenza, and that is mostly children under the age of 6 years old or people over the age of 65 years, and people who have chronic underlying medical problems. So particularly people with lung disease, chronic obstructive pulmonary disease or emphysema, as well as people with asthma, but also people with chronic heart disease, diabetes, or whose immune system doesn't function normally, either because of diseases like cancer or because of medications that suppress the immune system. There are lots of different complications that can occur with influenza. So in addition to the illness that I described with cough and fever, sometimes people can get infection in the sinuses called sinusitis. Children, most particularly, can sometimes get ear infections associated with influenza. Worsening of emphysema or asthma, we're going to talk about more in a moment. And then other lower respiratory infections, including croup. Influenza can sometimes cause pneumonia directly, so it gets into the lungs and it causes inflammation in the lung tissue that's evident on a chest x-ray, usually 3 to 4 days into the course of influenza, and again, more common in young children and in older adults. But importantly, people can also get bacterial infections after influenza sometimes, typically sort of toward the end of the influenza illness. So rather than just having a viral infection, now some people will develop bacterial infections that require antibiotics. I guess that's a good point to say that influenza isn't treated with antibiotics. We do have antiviral medications we use in some situations to treat influenza, but it does not require treatment with conventional antibiotics. we know that infections, and I'm sure you as people who have or are close to people with asthma know that infections are a common trigger for worsening asthma symptoms. Both viruses and bacteria can make asthma worse. So infections with viruses are felt to be the most common cause of worsening symptoms of asthma or exacerbations of asthma. And there's been many studies that tried to look at how frequently asthma exacerbations are associated with viruses. And you know from experience that viruses vary across the year how much they're around. So in the winter months, sort of from now in the fall through till April or early May, we have lots of respiratory viruses circulating. That's the dominant period for circulation of influenza, but it also happens to be the dominant time when we see circulation of many other respiratory viruses as well. So during that time, up to 80% or so of exacerbations of asthma in children are due to infections with viruses. That's a little less common in adults, and there's not quite as much information about that in adults, but certainly at least half of asthma exacerbations in adults are also due to infections by viruses. And as I mentioned before, people with asthma are also at higher risk for bacterial pneumonia, both in association with influenza, but even separate from influenza, people with asthma are at increased risk of pneumonia, and in particular of pneumonia due to a particular bacteria called pneumococcus. And so I was asked only to talk about influenza, so I will, but I will also mention here that people with asthma should also ask their doctor about vaccines against pneumococcal disease, because there are some recommended vaccines for that as well. It's difficult to say what proportion of exacerbations of asthma that are caused by viruses are actually caused by influenza, and the proportion varies, but generally speaking, it's about a third. So about a third of all exacerbations, viral exacerbations of asthma, are due to influenza. And of course, that depends on the season. So the worse the influenza season, the more influenza circulating in the community, the more of those exacerbations, will be due to influenza. And it's important to keep that in mind when we start to talk about vaccines, because influenza vaccine, of course, only prevents those exacerbations that are due to the influenza virus. So at the same time as influenza is circulating, there are other viruses circulating. So we would not expect influenza vaccine to prevent all wintertime worsenings of asthma that are due to viruses. It can only prevent the proportion that are due to influenza. In terms of how common influenza is, it's a very common infection. Again, typically between the sort of October through December at the earliest, often after Christmas, it picks up. Generally speaking, about between 10 and 20% of everyone in the community will get infected with influenza during an influenza season. And in some people, notably people over the age of 65 or people whose immune system doesn't function normally, up to 50% can get affected by influenza in a year. We don't really know how common hospitalizations are due to influenza, because it's not routine in all hospitals to test people coming into hospital with exacerbations of asthma, COPD, or other respiratory illnesses for influenza, so we don't systematically look for influenza. But we know from surveillance studies that are done that there's at least 12,000 hospitalizations in Canada due to influenza, and upwards of 3,500 deaths. And I think that grossly underestimates the true impact of influenza, again, because we only identify influenza using special tests, and those special tests are often not performed. It is clear, however, that of all the respiratory viruses that cause exacerbations of asthma and that cause pneumonia and hospitalization, influenza is the most important one and the only one, and the most important vaccine-preventable infection. Typically, influenza occurs in what we call seasonal epidemics, so it occurs with an abrupt onset of influenza, usually starting out west. Typically, we see influenza starting in the western provinces and BC and working its way eastward. The earliest we start to see flu is typically October or so, and then it peaks over the next few weeks and then lasts about 5 or 6 weeks, and then we start to see it trail off again. And I'll show you a picture of what that typically looks like in a minute. The severity of the influenza season depends on which influenza strains are circulating. I know Dr. Van Exan is going to talk a little bit more about the virus and the types of influenza, but generally speaking, there are 2 types of influenza A virus and 2 types of influenza B virus. And sometimes we see a season where one of those circulates, and sometimes we see seasons where many of them circulate. How severe the outbreak is also depends on how well the vaccine, the strains that have been selected for use in the vaccine match the strains that are circulating in the community. So you might hear about mismatch sometimes, and that means that typically that means that the influenza B strain that's in the vaccine, there's always 2 influenza A strains in a vaccine and 1 influenza B strain typically. And sometimes the influenza B strain that's not in the vaccine is the one that circulates most commonly. So that's when we describe a situation of mismatch. And that might lead to a worse season because there'll be less protection from vaccination. It also depends on how susceptible the population is. So that means how much of the population has been vaccinated against influenza that season, how good the immune system is of the population. So as the use of immune-suppressing medications increases, for example, we may see worse seasons because those people are more likely to be affected by influenza. And also how frequently people have been exposed to influenza in the past. So sometimes if we have a particularly bad influenza season one year, we might have a little bit lighter season the next year because people have been exposed to influenza recently. But one thing we can say about influenza is it's difficult to predict, and it's predictably unpredictable. So every year is different for us as infectious disease specialists and people who do vaccines. Influenza is one of those illnesses that's difficult to predict and always manages to surprise us. So this graph shows a typical pattern of influenza across the season. Week 52 is the last week of December, so you can see that typically we start to see the influenza season pick up in the latter part of the year, generally peaks somewhere around February or March, and then trails off, typically ending by May or so. Here you can see that we always look at the season based on the type of influenza that's circulating. So in the green bars, you can see all influenza. And then you can see that in this particular season, which I think is 2011-12, we had a mixture of influenza A viruses circulating and influenza B viruses circulating. And that will vary year to year. I run a network of hospitals across the country that tries to answer the question of how much influenza is causing hospitalization in adults in Canada, which has sites across the country. And we have been enrolling patients with influenza, lab-confirmed influenza in hospitals in Canada now across that network since 2009. I looked briefly before this meeting about how much we could say about asthma, and I can tell you that of the 4,800 or so patients with lab-confirmed influenza, these are all adults, so this will be different, probably underrepresent what would be the truth in children. But among the 4,800 or so adult cases of influenza hospitalized in our network, 17% of them were admitted with a diagnosis of exacerbation of emphysema or asthma, and 8% of all of our hospitalized patients with influenza had a diagnosis of asthma, an underlying diagnosis of asthma. So influenza vaccine is recommended actually in Canada now, recommended for all people over the age of 6 months because there is data suggesting benefit in patients of all ages. But in particular, patients with asthma are recommended to receive influenza vaccine each year. I'm just briefly going to talk about the 2 main types of vaccines, and then I know you'll hear more about this from Dr. Van Exan and our third speaker, Lynn. So there are 2 main types of influenza vaccines. The most common type that you've seen before are injectable vaccines that are killed vaccines. So these vaccines don't contain any live influenza virus, so they can't cause influenza because they don't have any live or whole virus in them. And they're typically made by chopping up the influenza virus into small pieces, and that's what's given to you in the vaccine to show your immune system the virus so that your body will make antibodies against influenza virus. And when you're then exposed later to influenza, your body says, oh, I've seen that infection before, I have antibodies and I can prevent infection. These non-live vaccines are the ones that are typically given by injection. And then there's a second type of vaccine that's newer, which is what we call a live attenuated vaccine. And this is a vaccine that's made from live influenza virus, so virus that can actually grow and replicate, but that's been treated in the laboratory so that it's not sufficiently strong virus that it can cause infection. So in this particular vaccine, the virus has been changed in the lab so that it can only grow at low temperatures. So it's able to grow in the front part of the nose, but not able to grow once it reaches the body temperature at the core in the lungs. So it replicates in the nose so that the body sees the virus and makes antibodies, but does not go down any lower in the lung or replicate to cause disease. As I mentioned, most influenza vaccines contain three types of influenza, 3 influenza strains, 2 influenza A strains, and 1 influenza B strains. And recently there have become available new vaccines that contain both 2 influenza A viruses and 2 influenza B viruses. And the idea with those vaccines is that we may be able to minimize how often we see mismatch, so how often a B strain circulates in the community that isn't in the vaccine or wouldn't have been in the vaccine if we only had 1 B strain there. So as I mentioned, everyone over the age of 6 months should get an influenza vaccine as recommended by the National Advisory Committee on Immunization, but most particularly those at highest risk of complications should get the vaccine, including people with chronic health problems, asthma included. Pregnant women should get vaccinated because we know that pregnant women are at higher risk of influenza complications and that vaccinating pregnant women will protect newborn infants because infants can't be vaccinated before 6 months of age. The vaccine just doesn't work in little babies. And importantly, people who have contact with these groups that are at high risk. So family members who are in close contact with people with asthma, pregnant women, kids under 6 months of age, for example, all of those close contacts we recommend being vaccinated because we can minimize the amount of influenza circulating around families with patients that are at high risk of complications. So by vaccinating them and by vaccinating their contacts, we can even more efficiently protect them from influenza. It's important to remember that influenza virus changes gradually in its composition over time, so it's a pretty smart virus, and it does change its characterization over time. And I think Dr. Van Exan will explain that in a little bit more detail. But because of that, it's important that people receive an influenza vaccine every year, because the vaccine from last year may well not protect. People ask, does the vaccine even work? Influenza vaccine gets a lot of attention in the media, sometimes justifiably, but often not. We know that there is no vaccine that is 100% effective, so that means that no vaccine will prevent 100% of the infection that it's meant to protect against, and that depends on whether the vaccine's well matched with the virus that's circulating, how well the person's immune system responded to the vaccine, and many other factors. But overall, influenza vaccine does prevent a significant amount of influenza illness in the community and also prevents a significant number of hospitalizations due to influenza. So if you only look at influenza in the community, the effectiveness of the vaccine is about 59 to 60% or so in healthy adults. Many studies showing it to be higher than that, but I think it would be fair to say at least 50%, up to 70% effective in that population. And importantly, the vaccine is also protective against the most severe complications of influenza, including hospitalization and death. And studies that have looked specifically at the severe complications of influenza show the vaccine to be more than 60% effective. In our studies in Canada over the last few years, mostly in elderly adults, the vaccine effectiveness ranges from about 40 to 60%. So you could say that that's terrible, or you could look at it to say we're preventing 40 to 60% of hospitalizations due to influenza in older adults in Canada. And I think that's an important message. We're going to talk a little bit more about the nasal flu vaccine. And so now the National Advisory Committee on Immunization recommends that, if possible, the nasal FluMist vaccine should be given preferentially to children over the injectable vaccine because it does work better. In terms of how well influenza vaccine prevents exacerbations of asthma, the data is a little bit conflicting, mostly because there's not a lot of studies looking at this, and recognizing that there's lots of different viruses that cause worsening of asthma symptoms over the winter season. It's not surprising that it's difficult to tease out how well the vaccine prevents those flares, but most studies have shown a reduction in the frequency of asthma exacerbations in people who receive flu vaccine compared to people who don't receive it. But certainly the prevention of severe disease, including hospitalization and death in people with asthma, is similar to that observed in the general population. I think I'll leave the discussion of the live attenuated flu vaccine spray to the third speaker in the interest of time. Side effects of the influenza vaccine are generally quite minor. Most people don't develop any side effects at all. Amongst people who do have any side effects from the injectable vaccine, the most common side effect is a sore arm. Some people get a little bit of tenderness at the injection site and a little bit of redness that lasts a few days. And that generally occurs in about 10% or less of people. Fever is an uncommon side effect of influenza vaccine, a little bit more common in children than in adults, but generally under 10% in all people. And there's clearly been studies that demonstrate no increased risk of wheezing after flu vaccine in asthmatics, and with some exceptions around the nasal mist, which we'll talk about in a few minutes. The only other thing I want to mention is that if your child is between 6 months and 9 years of age and receiving vaccine for the first time, they need 2 doses 1 month apart. 1 dose doesn't work. Egg allergy is not a problem with flu vaccine anymore, with injectable flu vaccine anymore, but people with egg allergy shouldn't get the nasal flu vaccine. So I'll stop there and just say, also ask about other vaccines you should receive.
Perfect. Thank you very much, Dr. McNeil. I believe we had a question from Kimberly, which I believe you just answered in your last slide there, but we do have a question from Sarah from Dundas, and she's wondering what turnaround time is for the production of vaccine and whether or not it would be possible to make a vaccine from a recent virus in time to treat the rest of the population, focusing on like a current outbreak.
Yeah, I think Dr. Van Exen's going to talk about that issue, so I'm going to leave that one to him.
Okay, perfect. So we will leave the questions for now. There will be an opportunity for additional questions for Dr. McNeil at the end of the presentation, and thank you very much for your very informative presentation. So we're going to turn it over to Rob Van Exen. Rob is a Killam postdoctoral fellow focusing on developmental cell biology. He's the director of immunization policy at Sanofi Pasteur and has 33 years of experience in vaccine research, development, manufacturing, commercial operations, and policy. He's also the chair of the Vaccine Industry Committee. So we thank Rob for joining us, and I turn the presentation over to him.
Thank you very much. So I will just start right in here talking a little bit about some of the issues we face in manufacturing a vaccine to prevent influenza. And of course, the big challenge that we have is that influenza is a tricky little bug, and it circulates around the world, and it travels from northern hemisphere the southern hemisphere and back again, and it keeps circulating and circulating. It likes the winter, and so when it's winter in the north, we have influenza in the north, and when it's winter in the south, of course, that's where it goes. That, of course, creates some problems, but it's made worse by the fact that as it travels and spreads around the world, it changes. And this is called genetic drift or shift. And really what's happening is that the virus is mutating a little bit as it travels through different populations and back and forth from the northern and southern hemisphere. Of course, because it changes, then people who are going to make vaccine must constantly change the vaccine to keep up with the changes in the virus. The vaccine basically has to match the virus that's circulating, and this is the biggest challenge in making vaccines for all of the manufacturers. And it's a huge enterprise, a global enterprise involving healthcare professionals in many different aspects of the medical community taking part in the process of allowing us to come up with vaccines. And I'll try and describe that briefly. The first thing we need to know is what viruses are circulating. And the way we find that out is that physicians and healthcare providers in the community agree to take samples from people who show any sign of a flu-like illness and send those off to the lab. And that information tells us a little bit about what viruses are circulating. Of course, this is done all over the world, and that information is passed on up to the national authority, and the national authorities pass it on up to the World Health Organization and the CDC in Atlanta. All of this data then about what viruses are circulating in the northern and southern hemisphere helps us to understand the trends and understand a little bit about how it's changing. So that's the analysis phase. The next phase is prediction. And this is where we go out on a limb a little bit, but once a year, well, actually twice a year, but once a year for the northern hemisphere, the World Health Organization goes out on a limb and says, these are the strains we expect to be a problem next year. And it's on the basis of that prediction that manufacturers start to make the flu vaccine. Now, over the years, we've been doing this for 40 years. We're getting actually pretty good at it, but every once in a while, a virus throws us a little wrinkle, and we have a year where we have a more problem with the vaccine than we would want. But most of the time, it works pretty well. Anyway, following the prediction, I've got to go back one here, is when the manufacturing starts. This usually starts in February. And so that samples of the virus that are isolated and that the World Health Organization and CDC have indicated will be the problem ones for next year are sent to the manufacturer. And there are a total of about 38 different manufacturers around the world. Most of them only produce locally. Companies in China tend to just produce for China and so on. But there are a few companies that produce for most of the large segments of the world. Anyway, they take that sample virus and start the manufacturing process. And I'll describe that a little bit more in a minute. Once it's been manufactured, and it takes about 6 months to do that, then the vaccine, of course, has to be distributed. And here we come back now to the very same people who are taking the samples are the same people who are going to give you your flu shot when it's flu season. So it's a big enterprise, and one would say, well, why so much effort on this virus, and the reason for that is, and Dr. McNeil described to you, this is a very serious virus. It's not your average one, and the other problem with this virus is it does periodically is prone to causing pandemics, which are very serious and result in a very large number of deaths. So it's a worthwhile enterprise, but it does involve a large group of people. So, having said that, how do the manufacturers make the vaccine? Well, as I indicated, around February, we get samples from the World Health Organization or the CDC of what is predicted to be the major strains that will be circulating in the following season. The manufacturers take those viruses and they tend to, the first step really is to adapt the virus to their manufacturing process so that they can maximize the amount of virus that they can produce. Once that's done, and a considerable amount of testing goes into that, they freeze the virus down into what we call seed banks, working seed banks, and it's virus from those, and the seed banks are very thoroughly tested to make sure there's nothing else in there but the specific viruses that we want, so that we're sure we're not going to give somebody some other thing that we don't want. So that's an important step. So it's only virus that comes from these validated seed banks that's used to make the vaccine. So then we start, once we have that, it's all tested, we take a little virus, we propagate it in a culture system. Most of the vaccines are still grown on eggs, but some are grown in other cell culture systems. But having said that, the job now is to expand or grow the virus so that we have lots of it to work with. And we have to do it one at a time. So if there's going to be 3 or 4 different viruses in the vaccine, we start with one virus, we grow it, and we produce what's called a monovalent bulk concentrate. And here we have a highly purified, highly concentrated concentrate of the virus in what we call a bulk format. And we do that for all the different types. And then the next step, of course, is to take the monovalents, and if we're going to put 3 or 4 different types of virus in the vaccine, we then have to blend them. And we then, once they're blended, we then have a trivalent or a quadrivalent bulk. And that is also stimulate the immune system. The other thing that happens during this process, and I haven't got that marked on the slide, but if it's a killed vaccine, of course the virus is killed by treating it with a chemical that will kill the virus. And secondly, the virus is often disrupted or broken up so that we're not using a whole virus, but we're using parts of whole virus. These 2 steps go on during the bulk production, and of course the purification process that comes in removes anything that's been used to manipulate the virus in that way. Finally, then, once we have a trivalent or quadrivalent vaccine that's at the right dilution, this has to go through sterile filling and packaging. It goes through a great deal of testing, and finally, the vaccine is ready to be tested in terms of safety testing and also to be approved by the regulatory authorities. And the regulatory authorities take a full month to retest the vaccine after the manufacturer has made it, tested it, so that everything is double tested. And this is how we maximize safety of the vaccine and make sure that these vaccines are suitable for use in the population. If we look at safety, it clearly is a priority, And if we look at how vaccines have evolved over the decades, one of the biggest changes has been in the way the regulator governs the manufacturing process. The good manufacturing practices, which all manufacturers have to abide by, have become much more stringent over time. And these basic regulations are based on maintaining sterility, maximizing the safety, minimizing the risk to the public, introducing stringent testing protocols, but in recent years have been more concerned about process control and redundancy, and making sure that not only nothing does happen, but nothing could happen. So there's a tremendous amount of effort put into quality oversight in the manufacturing regime, and again, this is all governed by the regulatory bodies in each of the countries. The other thing that's changed about vaccines over the years has been the number of virus strains that we've used. As Dr. McNeil alluded to, that there could be different number of virus strains in different vaccines. And in fact, prior to 1978, all influenza vaccines only had two strains. They had 1A subtype and 1B subtype. And that's what was used to protect people. And it did a pretty good job on the whole. But in 1977, there was a reappearance of a second A type that started to show up on a regular basis. And so at that point, manufacturers were asked to put 3 strains in the vaccine, 2 type A's, one for each of the major subtypes that circulate, the H3 and the H1, as well as the B strain. What we've seen recently since the mid-'80s is that the B virus is now starting to divide into 2 distinct lineages. There is the Victoria strain of B and the Yamagata strain of B. And again, this has become a problem in the last decade or so, which makes it hard to guess which one we should be putting in. So once again, manufacturers are starting to add now another strain to form what we call a quadrivalent vaccine. This is just about to become available in Canada within the next years or so, but certainly already available in the States and some of the South American countries. But it's expected that this will start to become the norm simply because our ability to predict which isn't very good. So we're going to put both of them in, and that should solve that problem. But as you can see, our technology with manufacturing flu vaccines has to keep up with a tricky little virus that keeps us on our toes. Other changes and innovations that have been brought into the manufacturing of flu vaccines relate to trying to deal with different kinds of problems. First of all, there's the manufacturing substrate. Traditionally, flu vaccines have been manufactured on embryonated eggs, and it's still the major and most robust form of manufacturing today. However, because of the recent pandemic in 2009, companies have been experimenting with a cell culture production methodologies, and these are starting to become available. And the main advantage to them is to reduce the lead time to manufacture the vaccine. It's not clear how robust those will be in terms of the virus changing every year yet, but as we get more experience with them and make adjustments to the manufacturing process, we will expect to get as consistent result as we do with the egg-based manufacturing. So again, we're trying with that technology to shorten the process from about 6 months to 5 months, or a little less if we can. The other change in vaccine technology that I won't talk about much here, but traditionally these vaccines have been made as inactivated whole organisms. In fact, back in the 40s and 50s, the first flu vaccines were made exactly the way some of the vaccines are made today, 60 years later. But the one new technology that's come out there is the live attenuated influenza virus vaccine, and I'll defer talking about that vaccine to our third speaker. But the point being is that those are newer technologies that are coming along. The other one is adjuvant technology, and this is just adding a substance to the vaccine that helps improve the immunogenicity. It's particularly used in people who are older who have effective immune system, and it's been used in a number of different strategies for influenza prevention. There's been changes in delivery technology. Most of the vaccines that are injectable are injected intramuscularly, but there has been the development of an intradermal injection. Uses a much smaller volume of vaccine, and the idea here is that it would get a larger response by injecting it into the dermis than you would from injecting into the muscle. The problem with that vaccine is that it's very expensive and generally has not found a home in the routine use, but it is another technology that's been developed. Finally, one that's available in the U.S. and would be coming to Canada over the next few years is a high-dose technology. And this is really just a matter of putting a lot more antigen in the vaccine. And the purpose of that is to compensate for people who have a depressed immune system, particularly the over 65 age group where we have to deal with immunosenescence. So that's pretty much what I want to say about the different technologies that have been developed. At the end of the day, vaccine effectiveness is about two things. It's about how well does the virus in the vaccine match up with the virus that's circulating, and it's about how strong your immune system is and how easily it's able to respond to the vaccine. And I won't spend a lot of time here. I think the numbers provided by Dr. McNeil on effectiveness are valid. At the maximum end, with a good match in a healthy individual with really good immune system, one could see effectiveness, but that is certainly not the majority of people. It's what you find in a controlled study where you're just looking at the healthiest of the healthy. However, as long as where you start to get into trouble is where you don't have a perfect match, and you can see the effectiveness drop to 40 to 60%, but it's still, as Dr. McNeil said, pretty good, better than nothing. So that even though the match isn't perfect, it still can provide protection. I think the other thing is, again, when we look in people with frail elderly, where the immune system is generally pretty non-responsive, the effectiveness can drop to 30 or 40% in terms of preventing disease. However, it's still a worthwhile use because it will tend to lessen the severity of the disease and can prevent deaths, and it can reduce hospitalizations. So it's still a benefit to use, even though you may be in a category where your immune system might not respond to it as well as one would like to. And then finally, as Dr. McNeil mentioned, that the effectiveness of the live attenuated vaccine has been shown to be greater and more important in young children and adolescents, and so there might be some benefits to use that one in that situation there. I think that's pretty well it, and I'll turn it back to our coordinator.
Thank you. Behind schedule. So for those of you that are not able to stay on, we certainly will continue. We are recording this meeting, and we will be posting it online and on social media. So if you are not able to stay with us until the end, then I think we will be able to get you the recording, and you can catch up on what you missed. But certainly, we're able to stay. We would love to have you stay with us for the remainder of the webinar. So I think we'll take one question now. We had a question from Kim from Ajax, who was wondering where the World Health Organization gets the sample of virus from each year.
Okay, so very quickly, as I mentioned, physicians take swabs from all around the world, frontline physicians. They are processed through the local laboratories. In Canada, it would go then up to provincial laboratories, and so these can be from Canada, the U.S., Mexico, any of these countries tend to get shipped on up to the World Health Organization, particularly ones that are of significance in terms of being newer or varieties that are potential to cause problems. So that's ultimately where they end up in a big laboratory repository at CDC in Atlanta or the World Health Organization.
Great, and we will we'll have some more questions that we will save until the end. So thank you very much, Rob. I'm going to turn it now to our last presenter. Lynn Douglas has been with AstraZeneca Canada since 1997, working the last 12 years as a medical advisor. She is responsible for being a medical and scientific expert for their product development as well as marketed products, liaising with physicians and collaborating on clinical development of new products and conducting and development of clinical studies. So we welcome Lynn, and I will turn the presentation over to you now.
Thank you very much. In the interest of time, I'm going to abbreviate my presentation somewhat because I think the previous two presenters have given a very eloquent presentation, and they've introduced you a little bit to the concept of the live attenuated vaccine. So that will be the focus of my discussion, and I just wanted to put a disclaimer up right up front to say that we do not promote the use of FluMist or FluMist quadrivalent outside of the Health Canada indication, which is for the active immunization of individuals aged 2 to 59 against influenza caused by virus subtypes A and B contained in the vaccine. So the learning objectives then is really, I just want to give you a brief overview of the product, the indication in Canada, which I just went through, the fact that we've had some very long-term experience with this product, even though it's only been available in Canada since 2010. Just touch a bit on the efficacy and safety in children and adults so you have an idea how it compares to the flu shot. We talked a little bit about already the extra B strain in the vaccine, and we actually have launched the quadrivalent formulation this year. So all the FluMist that we have in the Canadian market now has the 4 strains in it as of this year. It has been approved by Health Canada. I want to talk a little bit about some of the myths about the vaccine and really talk about its use in asthma. So I'll skip through quite quickly through the product profile. So just to be clear, the distinction between the flu shot and FluMist is, as Dr. McNeil said, with the flu shot, you break up the virus and you take the little proteins that are sitting on the surface of the virus, and that's really what is used in the vaccine. It doesn't cause illness, but it gives enough of your immune system a boost so that it recognizes that when it's exposed to it, and it can kill off that infection. With FluMist, it's a live vaccine, meaning that it has the full protein coat, so the body has several proteins that it can potentially recognize, and it develops a much more robust immune response. But the vaccine has actually been attenuated or changed in the laboratory so that it does not cause actual disease. It causes enough of an immune response, and you develop antibodies, but it does not cause an actual case of influenza. That's a common myth, that if you get a live vaccine that you're going to get sick from the vaccine and you're actually going to get the flu, and that's really not true. So what is FluMist and FluMist quadrivalent? So as we said before, it's a live attenuated influenza vaccine. It has all the strains that have been recommended by WHO each year. It is a gentle mist that's administered in the nose, and as Dr. McNeil already explained, it replicates only in the upper respiratory system, so it's in the back of the nose and the throat. It does not replicate in the lungs because it's temperature sensitive, and that is why it does not cause disease. It stimulates a more natural infection process when you actually get exposed to the droplets of flu in through the nasal cavity and in the nose, and that's where it replicates. So really we're stopping the influenza right where it starts. What's nice about this vaccine also, it's preservative-free, so there's no thimerosal or mercury for people who are concerned about those preservatives in some of the flu shots. It's adjuvant-free, so we don't add any additional alum or squalene to the vaccine. It's needle-free, so people who are needle-phobic or children who don't like to have needles, this is really a good alternative for those patients who really want to avoid needles. And the vaccine and spray are latex-free. And since 2003, more than 75 million doses of FluMist have been manufactured and distributed in the U.S. alone. So this product was available since 2003 in the U.S. As I said before, we've made it available in Canada since 2010. This is the first year that we've got the 4 strains. All the previous years we've had 3 strains. So FluMist is given as a mist. You can see on the left side of the screen the actual sprayer. It's just put into the nasal cavity. Half the sprayer is dispensed into one side of the nose, and then you give the rest into the other side. So it's very easy to administer. Children really tolerate it extremely well. This is what the actual sprayer looks like close up. It does have to be refrigerated at 2 to 8 degrees Celsius until it's ready to use. And it does have to be administered by a healthcare professional in case of any allergic reactions. And what also a lot of people are unaware is that you do not need a script for it except for the province of Quebec. You do need a script there, but everywhere else you can just purchase it at the pharmacy. And there's a website, FluMistCanada.ca, which has a pharmacy finder on it where you can actually go in, type in your postal code, and figure out which pharmacy is actually distributing it. In Canada, most public health units across the country are using the LAIV as an option for patients who do not wish to have the flu shot. The only exception is Ontario, where just a pilot program in school-age children is being run at the moment, and we don't have full public health usage at this point in time, but hopefully that will change down the road. So as I said, you can use this in children aged 2 to 59 years of age. Now, Dr. McNeil said that most recommendations suggest that after 6 months of age, but with FluMist, we do not recommend children under the age of 2 receiving it, older age population. So Health Canada has given us the indication up to age 59. In terms of contraindications, the only real contraindication is hypersensitivity to eggs, egg protein, or any of the other ingredients in the vaccine. And we do recommend precautions or care in patients who are immunocompromised, because those patients, their immune system may not be as good as a normal individual, and there is a very small theoretical risk of transmitting the actual vaccine virus to those patients. In pregnant women, we don't ever recommend using live vaccines. And in kids under the age of 18 who are taking aspirin therapy due to the potential for Reye syndrome, you need to be cautious using it in that group. Guillain-Barré was introduced with a previous flu vaccine, and that's true for inactivated vaccines as well. And then, of course, patients who have very severe asthma or active wheezing. And I'm going to talk a little bit more about the asthma afterwards, but certainly in well-controlled asthma, this is a very good option, and I'll show you a little bit of the data. And again, we don't administer to children under the age of 2. So as I said before, experience with LAIV is quite extensive. We've had a lot of vaccine recipients in clinical studies around the world. It's been widely used in children, the U.S. military, healthcare workers, and currently we've had about 980,000 doses distributed in Canada to date. The first H1N1 pandemic vaccine was available in the U.S., provided by MedImmune, and this is the first vaccine that was used for that pandemic. And since licensure, we've been doing ongoing safety monitoring, and certainly there haven't been any sort of new concerns that have been identified with the vaccine. As we said before, the flu vaccine is made up of 2 strains. I'm not going to go into this because we've already discussed this, but we do know that influenza B does contribute to a lot of the annual flu epidemics, and you can see in Canada over the past 10 years or so, it's been quite active in at least half of those seasons. So the B strain is very important to consider. And as we said before, with the trivalent formulations, you had a 50-50 chance of getting it right every year. And, there's the 2 strains that are circulating, and they alternate, Victoria and Yamagata. And we're not always very accurate in predicting which one is going to be circulating. And we get this mismatch that Dr. McNeil talked a little bit about earlier. So the B strain does cause significant morbidity in children and adults. You can see here that the B strain can cause a significant number of hospitalizations in the population. And so we have actually transitioned from the trivalent formulation to the quadrivalent formulation in Canada for this season. It's identical to trivalent with the exception of the additional B strain. It's been approved since February of 2012 in the U.S., and it was approved by Health Canada in our country this year on October the 3rd. In terms of efficacy and clinical performance, in adult patients, the TIV or the flu shot is equivalent in terms of efficacy to LAIV or QLAVE. In terms of children, as Dr. McNeil also had mentioned to you, it actually has better efficacy in children under the age of 17. So from age 2 to 17, it can actually reduce the cases of flu by about 50%. So it is recommended in children to use this preferentially over the flu shot whenever possible. It also has a longer duration of protection in children, and it also can protect against mismatched strains. Children are primary vectors of influenza. We call them the shutters and the spreaders. They tend to touch a lot of surfaces. They wipe their nose, and they shed influenza a lot longer than an adult. And they can be infectious for actually more than 10 days. And they can actually shed virus for up to 8 days prior to the appearance of symptoms. And they can then spread it to all the other susceptible people in the population, such as elderly grandparents, family members, people who are in the workplace or in the community. So really targeting children as a primary group for vaccine is really a good strategy. And this is what's called herd immunity. If you treat these patients in the community, you can potentially prevent the spread to others in the community that are more susceptible. So that's what I want to talk a little bit about just in children, and that's really where we're sort of targeting the use of FluMist. There's been 6 placebo-controlled studies where we compared the efficacy of the attenuated vaccine, the live attenuated vaccine versus just placebo. And you can see that there's good efficacy against it. And even in patients who have previously been unvaccinated and only received 1 dose, you still see some very good efficacy, even if they don't come back for a second dose. This is the pivotal trial that FluMist was registered on, and you can see that if you compare directly with the flu shot, you can reduce the cases by almost 55%. So this is really the study that suggests that it should be used preferentially in children. And this study was one of 3 studies where LAIV was compared to TIV, and very similar results were obtained in each of these studies. And just of note, the Fleming study at the bottom was done specifically in children with asthma, and again, it showed good efficacy. So efficacy in children, we definitely have demonstrated that 6 large placebo-controlled studies in subjects aged 6 to 71 months of age showed absolute efficacy. We have efficacy against both the B strains as well as the circulating A strains, and it's much higher efficacy compared to TIV in 3 studies in subjects aged 2 to 17. So one of the key myths about FluMist is that it can't be administered to asthmatics, and that actually is not true. It's not a contraindication for the use of this product. It should not be administered to individuals with severe asthma, which is really defined as patients who are receiving oral glucocorticosteroids or high-dose inhaled glucocorticosteroids, or people who've had active wheezing in the 7 days prior to vaccination. So it's a very specific group that need to stay away from this vaccine. But if you have moderate or well-controlled asthma, then certainly this is a good product and a reasonable choice. And there have been studies done in asthmatics, and this is the Fleming study that I referenced in the previous slide. If you look at the left-hand side of the screen, if you look at the number of flu cases, FluMist was extremely effective in reducing the number of flu cases compared to the flu shot. So the flu shot's in yellow, the FluMist is in green. And if you look on the right-hand side of the screen and you look at the actual side effects, there were no differences when you compared the flu shot with FluMist in terms of asthma exacerbations, hospitalization rates, unscheduled clinic visits, or increased medication use. So definitely it is safe to use in the asthmatic population, provided it's not severe asthma. In terms of the common adverse events, the most common side effect is a runny, kind of stuffy nose. It usually occurs within 1 to 3 days post-vaccination. You can also get a low-grade fever in children. Usually low grade is considered to be greater than 38 degrees Celsius. You can also get a bit of decreased appetite and irritability. And in adults, you get a very similar toxicity profile, except you can also get a bit of a sore throat and a bit of a headache. So Dr. McNeil also talked about NACI recommending the use of LAIV preferentially over the flu shot in healthy children and adolescents aged 2 to 17 without contraindication. And they also recommend that once available in Canada, the quadrivalent vaccine should be used in this group. I'm going to skip over this because we've already kind of talked about this. Certainly, if you needed to have additional information about FluMist, we do have a website, www.flumistcanada.ca, and you can certainly call our customer relations group at any time as well. So I think, we've covered today a lot of information about influenza and the fact that it really can be a very serious disease, and you really need to consider getting your flu shot on an annual basis because it does change every year. It's extremely important not only for yourselves, especially if you have something like asthma, but you should also consider preventing the spread to others who may be more susceptible in the population, such as very young children or elderly adults. You do need to get vaccinated every year, as we said. You do not get the flu from the flu vaccine, whether it's an inactivated vaccine or it's the FluMist live experience with these products in the market for many, many years, and it's benefited millions of Canadians since 1946. And it's extremely safe and it's well regulated through Health Canada. And everybody wins when you get vaccinated. So I'm going to stop there. And if there's any questions or comments, then certainly you can ask them.
Thank you very much, Lynn. We'll just move quickly through some of these extra slides here. Thank you for your presentation. We had a question from someone in the chat box about how they would go out purchasing FluMist, if you might know about the cost or if it varies by province.
The cost is really set, like in the private market, by the individual pharmacies. We have a factory price that we provide, which for FluMist was, I think it was $14, and I think I'm not sure what the quadrivalent price is. It's a little bit more than that, but certainly pharmacies can upcharge, or they can put on like administration costs and things like that. So it really depends on the pharmacy or where you purchase it from.
Okay, great.
It can range up to like about $25 to $30, somewhere in there. And it's usually reimbursed by private insurers.
Okay, thank you. And we have another question just regarding the risk or potential risk for people with severe asthma. Just wondering about what the definition of severe asthma is in that perspective, and how would you classify whether someone would be at risk with asthma?
So Health Canada was presented the respiratory guidelines that are well recognized within Canada. And so patients who, as I said before, have high-dose inhaled glucocorticosteroids, or they've had an exacerbation of their asthma, like within 7 days prior, should not take the drug, or the vaccine rather. If you've been stable on a certain regimen for a prolonged period of time and there's been no changes, no exacerbations, then that's something that your physician would probably okay you for in order to have the live attenuated vaccine.
Okay, great. And if there are
but there's
questions,
an algorithm.
Okay, thank you very much. And unfortunately, Rob has had to sign off the call, but we do still have Lynn and Dr. McNeil on the line. So if you have any further questions, please go ahead and type them into the chat box. We do have a couple questions here. I'm just watching the questions coming in. And there was a question about how the various viruses would travel through person to person, or is it traveling through the air when it's going from northern to southern hemispheres? I know that was coming out of Rob's presentation, but I'm not sure it's a question that either of the two of you would be able to answer.
Yeah, it's Shelly. So it is transmitted person to person dominantly, and as I said, it's not sort of, we hear a lot about airborne these days with the whole Ebola thing. It's not an airborne virus in the sense that it only is in those droplets that when people cough and sneeze. So you have to be pretty close to someone with flu. But again, because it's on surfaces, you can catch it, fairly easily in the mall and the like during flu season. In terms of how it gets from the north to the southern hemisphere, dominantly just through person-to-person transmission around the globe. So, people move around. As one country gets increasing flu, it moves to the next country and onward, always following winter, as Rob said.
Perfect. And there was a question about the potential side effect of paralysis and whether or not that's a side effect and if there's any noticeable data on that.
So perhaps the reference is to a syndrome called Guillain-Barré syndrome, and that's a neurologic condition in which the nerves get inflamed and people get usually a temporary paralysis that extends from the lower limbs and can move upwards. It's caused by a general inflammation in the nerves, and it has been shown to be associated with many infections, including influenza, and other infections that cause food poisoning, a bug in particular called Campylobacter. So in one flu season in the 1970s, there was an increased risk of this syndrome called Guillain-Barré following influenza vaccine. Very small increased risk, but an increased risk. But since that time, most studies that look at the sort of how much of this syndrome occurs in the general population without vaccine and compares to groups that have the vaccine show no increased risk, or if they show any increased risk at all, it's about 1 extra case per million people vaccinated. But most recent studies, even some done in Canada, have shown that the risk of Guillain-Barré syndrome, this paralysis called Guillain-Barré syndrome, is higher after naturally occurring influenza than it is after any vaccination. So that would suggest that by vaccinating, we will actually see reduced overall rates of this paralysis called Guillain-Barré than by not vaccinating, because people who get influenza are at higher risk than people who get vaccines.
Okay, thank you very much. We have a question from the chat window. Is there any risk with combined vaccines with monoclonal used for asthma?
What's the name of the monoclonal? Can somebody, is it a monoclonal that's immunosuppressive? I'm sorry, I'm not an asthma doctor, so I don't know what monoclonals are used for asthma.
We'll see if
I think
any
not, but
comments in the chat window.
if the drug is if any drug that suppresses the immune system might be a problem with the FluMist, but should not be with any of the other vaccines. I think neither of those. I don't know if Lynn would know the answer to that one.
I don't know specifically about those particular monoclonal antibodies, but certainly, as you just said, if there's any risk of immunosuppression because of the very low theoretical risk of transmitting the vaccine virus to a patient who is immunocompromised, you would want to avoid it. Certainly Health Canada has given some direction that anybody who's been exposed to live attenuated vaccines should avoid any immunocompromised patients. But that's really the only sort of main precaution that I can see, and I don't know that there would be any specific risk with the monoclonals. I'm not sure that they've actually been studied like in combination, but certainly that would be probably the main concern.
But that would definitely be a situation where I would ask your treating asthma doctor,
your physician, for sure.
That question, yeah, for sure.
It really is
definitely no problem with the injectable vaccines, but I think the question there would be around the safety of the FluMist. So that's something that you should definitely ask your doctor about.
Great. And I would also add if there are any asthma specific questions that you have, you can also submit a question to info@asthma.ca, or you can call 1-866-687-4050, which is our main office line, and you can ask a question through our asthma and allergy information line, and that and those questions get sent to certified asthma and respiratory educators, and they will then be in touch with answer to your question within a day or two. So we're always happy to.
Noah.
Yes.
I think there was also a question about pharmacists administering the vaccine. I think up further, I just wanted to address that because there are certain provinces that allow pharmacists to actually administer vaccine, but they have to be accredited by their own organization, and they have to undergo some training. So it depends on the province that you're in, whether or not you can actually get the pharmacist to administer. So in Ontario, for example, there are pharmacists that can administer vaccines. So yes, they can definitely do it, but it depends on their individual college of pharmacy.
And if you have any questions around what the access information would be in your local community, please feel free to send me an email, again, noah@asthma.ca, and I'm happy to let you know where you would best be able to receive the flu vaccine. So I think we'll wrap up now. I want to thank our speakers for very informative presentations, both Lynn and Dr. McNeil, and of course Rob, who saw us. We appreciate your time and the information that you provided, and of course, thank you very much to all of our participants. We hope that you found this first NAPA patient webinar to be interesting and informative. We hope to be able to do these regularly throughout 2015, and so please stay tuned for future announcements of topics. And again, if you have any feedback on potential topics or things that you think you would like us to focus on, please let us know. You can follow us online on Twitter @Asthma Society or on Facebook Asthma Society of Canada, and of course you can sign up to be a member of our National Asthma Patient Alliance for free, asthma.ca/NAPA, and that will get you on all of our emails moving forward. So thank you very much, everyone, and I hope everybody has a great day.
Thank you.